So look, basically with respect to time, I won't spend too much time going through this because we want to keep discussions going. But just to update on the actual LAPPRO outcomes, there was no difference in continence at 2 years between robotic and open surgery. There was no difference in recurrence rate, but there was a positive outcome in favour of the robotic arm with respect to local recurrence in PT3 disease, and also with respect to a favourable outcome with respect to erectile function. But in a non-randomised trial, it's very difficult to exclude selection bias, and that's one of the complications, or one of the concerns with interpreting this data. Now, with the current study we're going to talk about, which is the Surgeon Heterogeneity, I've always felt if you're going to remove the prostate or any organ with the same technique, then the functional and oncological outcomes you'd expect to be similar, whether you did it by an open or a laparoscopic or a robot-assisted laparoscopic approach. So I think the strength of our randomised controlled trial was that it was randomised with 2 experienced surgeons, experienced their technique and good surgical procedures. Although LAPPRO wasn't randomised, the strength of the LAPPRO study was there were a lot of different surgeons with different surgical techniques in a community setting with different caseloads. And the beauty of this study is they then adjusted for the surgeon techniques, not just pathology outcomes, not just patient factors, also surgeon factors with respect to nerve sparing, surgeon experience and your caseload. And this trial had the unique opportunity, unlike our trial, of really looking at the outcomes of the least experienced surgeons and the most experienced surgeons in the trial. So what I was really interested in is whether this would show, whether this study would show that inexperienced surgeons could master the radical prostatectomy technique and become competent faster than open surgeons. And whilst I'm not sure that the trial actually answered that question, the really interesting point was that if you look at the surgeons with the highest volume, the 12 surgeons with the highest volume, there was still a significant difference in an outcome with respect to incontinence and erectile function. And so it was clear to me that heterogeneity is not just about the number of cases you do per year, but it's also relates, I think, especially to previous training, surgical technique, and clearly attention to detail. And if you're in a high volume centre watching the webinar and you think, well, 41 cases as the annual caseload is low, that's not necessarily true. Although this trial had some biases, the open surgeons were more experienced before the trial started, and the robotic surgeons did a higher annual caseload during the trial. 41 cases may seem to high volume surgeons not a lot, but that reflects to the community setting. This is our caseload in Australia, and in Australia, the median number of robotic prostatectomies performed by surgeon each year is 25, 63 over a 3-year period, and 40% are performed by surgeons who do less than 20 cases a year. So the trial looked at a lot of different things, and it's really important. Your outcomes can depend on what you're looking at. If you're looking at baseline analysis in the annual caseload, then open surgery appeared to give better continence. But if you then added prior experience in nerve sparing, the statistical significance was not there. And similarly with erectile dysfunction, it's unchanged by annual caseload and nerve sparing, but it changes if you've got the inclusion of prior surgeon experience. So the important thing to me was that annual caseload itself did not independently impact the functional outcomes. And that to me stressed the importance of the surgical training we get before we start on our careers. So just really, this was a statement in the discussion section of the manuscript, and it was a really good statement to me. It just really put together the important factors, and that is, how do we train our urology registrars to become competent robotic surgeons? How do we transition open surgeons to become competent robotic surgeons? And what are the basic skills required for surgeons to start a solo independent robotic practice? And then what's the annual caseload required? I think training is very important. I know Tony Costello in Melbourne is really looking at a training module to help us develop laparoscopic skills, and it's a really good program, and that's the sort of thing we need. And finally, just the final slide is, you know, what specific publicly available data do we provide about patients to let them make an informed decision about their choice of surgeon? And it appears that surgeon is a very important factor in the outcome following a robotic or an open radical prostatectomy. And just finally, it's not just about surgeon skills, it's about other characteristics of being a surgeon with empathy, good communication skills. We don't cure all the people we operate on. There's about 30% of men will end up with biochemical recurrence after prostate cancer, probably 50% if you're operating on the high-risk cohort. And so this is a lifelong relationship and survivorship with our patients, and that's very important. So there's some simple points that I thought I came through when I looked at this talk.